Today we will be describing the mechanisms of labour. The baby will be in a cephalic longitudinal lie, which is the most common presentation. Engagement. Engagement is when the largest diameter of the fetal head fits into the largest diameter of the maternal pelvis. As the fetal head engages, the head moves towards the pelvic brim in either the left or right occipito-transverse position, so the widest part of the head fits through the widest part of the pelvic inlet. Descent. Here the baby descends through the pelvic inlet towards the pelvic floor. Descent occurs because of uterine contraction, pressure of the amniotic fluid, and voluntary contraction of the abdominal muscles by maternal effort. Flexion. As the fetus descends, its head comes into contact with the pelvic floor. This causes flexion of the fetal neck, chin to chest, allowing the presenting part of the fetus to be suboccipitobregmatic. This creates a smaller diameter for the passage through the pelvis. Internal rotation. The pelvic floor has a gutter shape with a forward and downward slope. This allows the head to eventually rotate from the left or right occipito-transverse position 90 degrees medially to an occipito-anterior position to lie under the suprapubic arch. This eventually results in crowning. Crowning is clinically noted when the head no longer retreats after contractions and becomes visible at the vulva. Extension. Here the occiput slips beneath the suprapubic arch, causing extension of the fetal head. As this extension occurs, the fetal head pushes against the perineum, causing it to stretch. External rotation and restitution. The head externally rotates to face the right or left medial thigh of the mother. At the same time, the shoulders are also rotating from a transverse position to an anterior-posterior position to realign 90 degrees with the head. This realignment is called restitution. Delivery of the shoulders and body. The midwife applies downward traction to the fetal head to assist the delivery of the anterior shoulder below the suprapubic arch. This is followed by upward traction assisting the delivery of the posterior shoulder. The baby can then be delivered.
Before labour, the baby can be in a number of different positions. These positions could be predicted by a thorough pregnant abdominal examination.
In a longitudinal presentation, the baby could either be breech or cephalic. In cephalic, the baby could be occipito-anterior and move clockwise. Right occipito-anterior, right transverse, right occipito-posterior, occipito-posterior, left occipito-posterior, left occipito-transverse, left occipito-anterior, and back to the start occipito-anterior. The baby could also be in the following two transverse positions: a right transverse position and a left transverse position. Less commonly, the baby could be in an oblique position, right or left.
Today we have described the mechanisms of labour and the positions of the baby in the pelvis. To summarise, the mechanisms of labour are split into several key parts: engagement, descent, neck flexion, internal rotation, crowning, extension, external rotation and restitution, delivery of the shoulders, and delivery of the baby.